Question 1. A 62-year-old male patient presents with a history of progressive shortness of breath, a persistent cough, and a low-grade fever over the last few weeks. He has a history of smoking for 30 years and has been diagnosed with chronic obstructive pulmonary disease (COPD) in the past. His physical examination reveals diminished breath sounds, prolonged expiratory phase, and use of accessory muscles of respiration. A chest X-ray, hyperinflation of the lungs, and a computed tomography (CT) scan reveals a possible consolidation in the right lower lobe. Which of the following is the most likely diagnosis for this patient? A. Pneumothorax. B. Community-acquired pneumonia. C. Acute exacerbation of COPD. D. Pulmonary embolism. Answer: C. Acute exacerbation of COPD. Explanation: this patient's presentation of worsening shortness of breath, cough, low-grade fever, and physical examination findings of diminished breath sounds and prolonged expiratory phase is indicative of an acute exacerbation of COPD. COPD exacerbations are commonly triggered by respiratory infections, environmental factors, or environmental pollutants. The hyperinflation noted on the chest X-ray, consolidation seen on the CT scan may suggest a bacterial infection or superimposed pneumonia, which frequently occurs in individuals with COPD. Pneumothorax would cause sudden chest pain and difficulty breathing, but it is not a typical complication of COPD unless there is severe emphysema with bleb formation. Community-acquired pneumonia could be considered in a patient with fever, cough, and consolidation, but the underlying diagnosis, COPD and the lack of acute onset, make it less likely. Pulmonary embolism would present with sudden onset chest pain, dyspnea, and often a history of risk factors such as prolonged immobility, which is not described here. Question 2. Which of the following best describes the mechanism of action of beta blockers in the management of hypertension? A. They dilate peripheral blood vessels, reducing systemic vascular resistance. B. They inhibit the renin-angiotensin-aldosterone system, decreasing blood pressure. C. They reduce heart rate and myocardial contractility, lowering cardiac output. D. They block calcium channels in vascular smooth muscle, causing vasodilation. Answer: C. They reduce heart rate and myocardial contractility, lowering cardiac output. Explanation: beta blockers primarily work by blocking beta-adrenergic receptors in the heart, leading to a reduction in heart rate, chronotropy, and myocardial contractility anotropy. This results in a decrease in cardiac output, which is a key determinant of blood pressure. By decreasing cardiac output, beta blockers are effective in lowering blood, especially in hypertensive patients with increased sympathetic tone. Option A is incorrect because beta blockers do not directly dilate blood vessels. Their primary action is on the heart. Option B is incorrect because beta blockers do not directly inhibit the renin-angiotensin-aldosterone system, although they may have a secondary effect on this pathway. Option D describes the action of calcium channel blockers, not beta blockers. Calcium channel blockers decrease calcium influx into vascular smooth muscle, causing vasodilation. Question 3, scenario-based. Mr. Davis is a 50-year-old male with a history of poorly controlled type 2 diabetes mellitus and hypertension. He presents to the clinic complaining of new-onset blurry vision in both eyes and intermittent dizziness over the past month. His blood pressure is 180/100 mmHg and his blood glucose is 250 mgl. His ophthalmic exam reveals microaneurysms and hemorrhages. Mr. Davis asks what the most likely cause of his symptoms is. What should be the next step in the management of this patient? A. Initiate treatment with insulin and a beta blocker for blood pressure control. B. Start an ACE inhibitor and refer to an ophthalmologist for further evaluation. C. Refer for immediate CT brain imaging to rule out stroke. D. Increase the dose of oral hypoglycemic medications and monitor for signs of stroke. Answer: B. Start an ACE inhibitor and refer to an ophthalmologist for further evaluation. Explanation: this patient is presenting with symptoms consistent with diabetic retinopathy, a complication of poorly controlled diabetes that causes microaneurysms and retinal hemorrhages, which can lead to blurry vision. His poorly controlled blood pressure, hypertension, and elevated blood glucose contribute to the development and progression of diabetic retinopathy. Management should focus on controlling blood pressure and blood glucose levels. ACE inhibitors, option B, are effective in managing hypertension, particularly in patients with diabetes, as they also provide renal protection. They should be started promptly in a patient with diabetes and hypertension. Referring to an ophthalmologist for further evaluation of the retinopathy is essential for monitoring and managing this complication. Option A is not appropriate because insulin therapy alone is not sufficient to manage the patient's blood pressure, and beta blockers are not first line for hypertension in diabetic patients. Option C is not the next step because the patient's symptoms are more likely related to diabetic retinopathy rather than a stroke. While dizziness is a symptom of stroke, it is more likely secondary to the patient's uncontrolled blood pressure and diabetes. Option D is incorrect because increasing the dose of oral hypoglycemic medications alone does not address the hypertension or the potential diabetic retinopathy. Monitoring for signs of stroke is not priority at this stage. Question 4. A 45-year-old female presents to the emergency department with severe abdominal pain, nausea, vomiting, and fever for the past 24 hours. She has a history of diabetes mellitus and is on insulin therapy. On physical examination, she has right upper quadrant tenderness, jaundice, and a positive Murphy sign. Laboratory results show an elevated white blood cell count and liver function tests. An ultrasound reveals gallstones and thickening of the gallbladder wall. What is the most likely diagnosis for this patient? A. Acute pancreatitis. B. Acute cholecystitis. C. Hepatitis. D. Peptic ulcer disease. Answer: B. Acute cholecystitis. Explanation: this patient's presentation, including right upper quadrant pain, fever, jaundice, and a positive Murphy sign pain with palpation of the gallbladder during inspiration, is consistent with acute cholecystitis. The ultrasound findings of gallstones and thickening of the gallbladder wall further support this diagnosis. Acute cholecystitis is often caused by obstruction of the cystic duct by gallstones lead to inflammation of the gallbladder. Acute pancreatitis, option A, would typically present with epigastric pain radiating to the back and elevated amylase and lipase levels, not primarily right upper quadrant pain and Murphy's sign. Hepatitis, option C, would be more likely to present with generalized abdominal discomfort, fatigue, and jaundice, but without the localized tenderness seen in this patient. Peptic ulcer disease, option D, would present epigastric pain, often related to meals, and would not explain the fever, right upper quadrant pain, and positive Murphy sign. Question 5. A 38-year-old male presents with fatigue, weight loss, polyuria, and increased thirst. His random blood glucose is 350 mdl and his hemoglobin AC is 9.5%. The patient is diagnosed with type 2 diabetes mellitus. Which of the following is the most appropriate initial management for this patient? A. Start insulin therapy immediately. B. Initiate lifestyle modifications and metformin therapy. C. Prescribe sulfonylureas as first-line therapy. D. Begin a glucagon-like peptide 1 receptor agonist GLP-1 therapy. Answer: B. Initiate lifestyle modifications and metformin therapy. Explanation: the first-line treatment for type 2 diabetes mellitus is lifestyle modifications, including dietary changes and physical activity, and metformin therapy. Metformin works by decreasing hepatic glucose production and improving insulin sensitivity. This approach is effective in the majority of patients, especially in those who are not yet experienced complications or requiring insulin therapy. Option A is incorrect because insulin therapy is not typically started immediately for most type 2 diabetes patients, except in cases of severe hypoglycemia or if the patient is symptomatic or in diabetic ketoacidosis. Option C is incorrect because sulfonylureas are not first-line agents and are typically used when metformin alone is insufficient. Option D is incorrect because GLP-1 receptor agonists, while useful in some cases, are generally not first-line treatments for type 2 diabetes, especially in newly diagnosed patients. Question 6. A 60-year-old male with a history of hypertension and hyperlipidemia presents with sudden onset weakness on the right side of his body, slurred speech, and difficulty understanding language. His vital signs are stable and AK. The brain shows no evidence of hemorrhage. What is the most likely diagnosis for this patient? A. Transient ischemic attack TIR. B. Ischemic stroke. C. Seizure. D. Hypoglycemia. Answer: B. Ischemic stroke. Explanation: this patient's presentation of sudden onset weakness on one side of the body, hemiparesis, slurred speech, dysarthria, and difficulty understanding language. Aphasia suggests an ischemic stroke, likely due to blockage of an artery supplying the brain. The absence of hemorrhage on CT scan does not rule out ischemic stroke, which can be diagnosed with clinical findings and imaging. Transient ischemic attack. Option A involves temporary neurologic deficits that resolve within 24 hours, but this patient's symptoms are still ongoing and are not transient. Seizure option C typically presents with generalized convulsions or focal seizures with postictal confusion, which is not seen in this case. Hypoglycemia option D could present with confusion or altered mental status but would typically cause more diffuse change in consciousness, specific focal neurologic deficits. Question 7, scenario-based. Mr. Thompson, a 7-year-old male, presents with complaints of joint pain in his knees and wrists for the past few months. He has a history of morning stiffness that lasts for about 30 minutes and experiences swelling in his joints, particularly in the wrists. He also reports fatigue and mild weight loss. His physical examination shows symmetrical joint swelling, especially in the hands and wrists, with decreased range of motion. Laboratory findings reveal positive rheumatoid factor and elevated erythrocyte sedimentation rate, ESSER. What is the most likely diagnosis for this patient? A. Osteoarthritis. B. Gout. C. Rheumatoid arthritis. D. Psoriatic arthritis. Answer C. Rheumatoid arthritis. Explanation: Mr. Thompson's presentation is consistent with rheumatoid arthritis, an autoimmune disorder characterized by symmetrical joint pain, stiffness, especially in the morning, joint swelling, and fatigue. Typically affects smaller joints such as the wrists and hands, and positive rheumatoid factor and elevated ESSER further support this diagnosis. Osteoarthritis option A typically affects weight-bearing joints such as the hips and knees and presents with pain that worsens with activity, not morning stiffness or symmetrical joint swelling. Gout option B is characterized by sudden severe pain and swelling, usually in the big toe, podagra, and is not associated with symmetrical joint involvement or elevated rheumatoid factor. Psoriatic arthritis option D often affects the fingers and causing sore digits and may be associated with skin rash, which is not described in this case. Question 8. A 45-year-old male presents with chest pain that started suddenly while he was exercising. He describes the pain as a pressure-like sensation in the center of his chest, which radiates to his left arm. His past medical history is significant for hyperlipidemia, smoking, and a family history of heart disease. His ECG shows some segment elevation in the anterior leads. What is the most likely diagnosis? A. Stable angina. B. Unstable angina. C. Acute myocardial infarction. STEMI. D. Aortic dissection. Answer C. Acute myocardial infarction. STEMI. Explanation: this patient's presentation of sudden onset chest pain with pressure-like quality, radiation to the left arm, and segment elevation on the ECG is highly indicative of an acute myocardial infarction. STEMI. STEMI results from complete occlusion of coronary artery, leading to myocardial ischemia and infarction. Stable angina option A typically presents with chest pain, relieved by rest, and does not occur at rest or during exercise. Unstable angina option B would present with chest pain that occurs at rest or with minimal exertion, but it does not show segment elevation on the ECG. Aortic dissection option D would present with tearing chest pain, often associated with history of hypertension or connective tissue disorders, and may show widened mediastinum on chest imaging. Question 9. A 52-year-old female with a history of obesity and hypertension presents with sudden onset shortness of breath, pleuritic chest pain, and a cough that produces blood-tinged sputum. She has a history of deep vein thrombus DVT in the past. On physical examination, she has tachypnea, tachycardia, and decreased breath sounds on the left side. Her pulmonary angiogram reveals a large thrombus in the pulmonary artery. What is the most appropriate initial management for this patient? A. Start intravenous heparin and arrange for thrombolysis. B. Administer oxygen and initiate a diuretic regimen. C. Start low molecular weight heparin and arrange for surgical embolectomy. D. Initiate warfarin therapy and discharge for outpatient management. Answer A. Start intravenous heparin and arrange for thrombolysis. Explanation: this patient is presenting with a pulmonary embolism, P, likely due to a history of DVT and the sudden onset of pleuritic chest pain, shortness of breath, and hemoptysis. Initial management involves starting intravenous heparin to anticoagulate the patient and prevent further clot formation. Thrombolysis may be indicated for massive hemodynamic instability. Option B is incorrect because diuretics and oxygen therapy alone are not sufficient to manage a P. Option C is incorrect because surgical embolectomy is typically reserved for patients who are not candidates for thrombolysis or when thrombolysis fails. Option D is incorrect because warfarin is not initiated as the first-line therapy in the acute setting. Heparin or low molecular weight heparin is preferred initially. Question 10. A 60-year-old male with a history of chronic alcohol use presents to the emergency department with confusion, tremors, and sweating. He is disoriented to time and place, and his blood pressure is elevated. His family reports that he has not had a drink for 48 hours. His laboratory results show a mild metabolic acidosis, and his serum electrolytes are normal. What is the most likely diagnosis? A. Alcohol intoxication. B. Alcohol withdrawal delirium, delirium tremens. C. Wernicke-Korsakoff syndrome. D. Hypoglycemia. Answer: B. Alcohol withdrawal delirium, delirium tremens. Explanation: this patient's presentation of confusion, tremors, sweating, and elevated blood pressure after cessation of alcohol use is consistent with alcohol withdrawal delirium, delirium tremens, which typically occurs 4-8-72 hours after the last drink. The symptoms include agitation, confusion, autonomic hyperactivity, tachycardia, hypertension, and hallucinations. Alcohol intoxication, option A, would occur during drinking, not after cessation. Wernicke-Korsakoff syndrome, option C, typically presents with confusion, ataxia, and ophthalmoplegia. Wernicke's followed by amnesia and confabulation. Korsakoff's and is associated with thiamine deficiency, not alcohol withdrawal. Hypoglycemia, option D, could cause confusion and sweating, but would likely have low glucose levels on lab work, which this does not show. Question 11. A 55-year-old woman presents with complaints of hot flashes, night sweats, and irregular periods. She is also experiencing mood swings and difficulty sleeping. Her last menstrual period was 11 months ago. What is the most likely diagnosis? A. Premenstrual syndrome, PMS. B. Perimenopause. C. Hypothyroidism. D. Polycystic ovary syndrome, PCOS. Answer: B. Perimenopause. Explanation: this patient is likely experiencing perimenopause, the transition phase before menopause, characterized by irregular periods, hot flashes, night sweats, mood swings, and sleep disturbances. The symptoms are typically seen in women between 45 and 55 years of age and often last for several years. Premenstrual syndrome, PMS, option A, occurs before menstruation, not during the perimenopause phase. Hypothyroidism, option C, may cause symptoms such as weight loss, tachycardia, and heat intolerance, but does not typically cause hot flashes and irregular periods. Polycystic ovary syndrome, PCOS, option D, usually affects younger women and is associated with irregular periods, but it does not typically cause the characteristic hot flashes or night sweats seen in perimenopause. Question 12. A 25-year-old female presents with severe lower abdominal pain, fever, and vaginal discharge. On pelvic examination, she has cervical motion tenderness and adnexal tenderness. Her urine pregnancy test is negative, and a pelvic ultrasound shows an enlarged, tender left ovary with a complex cystic mass. What is the most likely diagnosis? A. Ovarian torsion. B. Ectopic pregnancy. C. Pelvic inflammatory disease PID. D. Endometriosis. Answer: C. Pelvic inflammatory disease PID. Explanation: this patient's symptoms of lower abdominal pain, fever, cervical motion tenderness, and adnexal tenderness, along with the ultrasound finding of an enlarged, tender ovary, are most consistent with pelvic inflammatory disease PID. PID is an infection of the female reproductive organs, often caused by sexually transmitted infections such as chlamydia or gonorrhea. Ovarian torsion, typically presents with sudden severe unilateral lower abdominal pain, often without fever or vaginal discharge. Ectopic pregnancy, option B, can cause lower abdominal pain and vaginal bleeding, but the urine pregnancy test would be positive in most cases. Endometriosis, option D, can cause pelvic pain and tenderness, but it is not typically associated with fever or a tender enlarged ovary on ultrasound. Question 13. A 30-year-old female presents with fatigue, weight gain, cold intolerance, constipation, and dry skin. On examination, her heart rate is 58 beats per minute and she has a puffy face and a coarse voice. Her thyroid function tests show an elevated TSH level and a low free level. What is the most likely diagnosis? A. Graves' disease. B. Hashimoto's thyroiditis. C. Hypothyroidism. D. Thyroid cancer. Answer: B. Hashimoto's thyroiditis. Explanation: this patient presents with symptoms of hypothyroidism including fatigue, weight gain, cold intolerance, and dry skin. The elevated TH and low Freed levels confirm the diagnosis of hypothyroidism. Hashimoto's thyroiditis is the most common cause of hypothyroidism, an autoimmune disorder where the immune system attacks the thyroid gland, leading to decreased thyroid hormone production. Graves' disease, option A, causes hypothyroidism characterized by weight loss, heat intolerance, and tachycardia, which is the opposite of this patient's symptoms. Hypothyroidism, option C, would present with decreased TH and elevated Freed, not the opposite. Thyroid cancer, option D, typically does not cause the systemic symptoms seen in this patient and would usually present as a neck mass or nodule rather than hypothyroidism. Question 14, scenario-based. A 42-year-old male presents with a 2-week history of persistent cough, fever, chills, and night sweats. He has a history of close contact with a family member who was recently diagnosed with tuberculosis (TB). On examination, he has crackles in the left lower lung field and lymphadenopathy. A chest X-ray shows a left lower lobe infiltrate. The sputum culture grows Mycobacterium tuberculosis. What is the most appropriate next step in management? A. Start empiric antibiotic therapy for community-acquired pneumonia. B. Start directly observed therapy with anti-tuberculosis medications. C. Hospitalize the patient for isolation and supportive care only. D. Prescribe a corticosteroid for inflammation. Answer. B. Start directly observed therapy with anti-tuberculosis medications. Explanation. This patient has active tuberculosis (TB) as evidenced by the positive sputum culture for Mycobacterium tuberculosis, and he has a history of close contact with someone who had TB. The next step is to start directly observed therapy with anti-TB medications, which typically includes a combination of isone, rifampin, pyrazinamide, and ethambutol for the first 2 months, followed by a continuation phase of isoniazid and rifampin. Option A is incorrect because the patient has TB, not community-acquired pneumonia, and requires specific anti-TB treatment, not broad-spectrum antibiotics. Option C is incorrect because hospitalization for isolation and supportive care alone is insufficient. TB treatment should be initiated immediately. Option D is incorrect because corticosteroids are not used in the treatment of TB unless there is significant inflammation or complications such as TB-related meningitis or pericarditis. Question 15. A 45-year-old male presents with a history of increasing fatigue, shortness of breath, and swelling in both legs over the past few months. He has a history of hypertension and diabetes. On physical examination, he has bilateral pitting edema in the lower extremities, a displaced apex beat, and a loud gallop. His chest X-ray shows cardiomegaly, and his ECG reveals sinus tachycardia with nose and segment changes. His laboratory results show elevated BNP levels. What is the most likely diagnosis? A. Acute myocardial infarction. B. Chronic kidney disease. C. Congestive heart failure, CHF. D. Pulmonary embolism. Answer. C. Congestive heart failure, CHF. Explanation. This patient's presentation of fatigue, shortness of breath, lower extremity edema, displaced apex beat, escallop, cardiomegaly on chest X-ray, elevated BNP levels, and the absence of acute ischemic changes on the ECG is consistent with congestive heart failure. SHF results from the heart's inability to pump blood effectively, causing fluid retention, edema, and symptoms of poor perfusion. Acute myocardial infarction, option A, typically presents with chest pain and segment changes on the ECG, neither of which are present in this case. Chronic kidney disease, option B, can cause fluid retention and edema, but it would not explain the other cardiovascular findings such as an gallop and cardiomegaly. Pulmonary embolism, option D, can present with shortness of breath and chest pain, but would more likely cause sudden onset symptoms and is typically associated with hypoxia and an elevated D-dimer, neither of which are present in this case. Question 16. A 70-year-old female presents with new onset tremors, rigidity, and bradykinesia over the past 6 months. Her family reports that she has become increasingly slow in performing daily activities and has difficulty getting out of chairs. Her handwriting has become smaller and more cramped. Neurological examination reveals a resting tremor, cog, or rigidity, and a shuffling gait. What is the most likely diagnosis? A. Alzheimer's disease. B. Parkinson's disease. C. Multiple sclerosis. D. Essential tremor. Answer. B. Parkinson's disease. Explanation. This patient's symptoms of resting tremor, rigidity, bradykinesia, and shuffling gait, along with small handwriting, micrographia, are characteristic of Parkinson's disease. Parkinson's disease is a neurodegenerative disorder that primarily affects the basal ganglia, resulting in motor symptoms like tremor, rigidity, and bradykinesia. Alzheimer's disease, option A, primarily affects memory and cognition, not motor control. Multiple sclerosis, option C, typically presents with relapsing and remitting neurological deficits, including sensory and motor symptoms, and is not characterized by resting tremors. Essential tremor, option D, causes tremors, but it is typically postural and action-based, not resting. Additionally, it does not cause the other classic motor features. See Parkinson's disease, such as rigidity and bradykinesia. Question 17, scenario-based. A 60-year-old male presents to the clinic for a routine checkup. He is asymptomatic but has a family history of heart disease and diabetes. He is a current smoker and drinks alcohol occasionally. His blood pressure is 106 to 90 millimeters Hg and his fasting glucose is 120 mgl. His cholesterol levels show an LDL of 106 mdl and total cholesterol of 204 mdl. CMI is 32. What is the most appropriate next step in management for this patient? A. Initiate statin therapy immediately. B. Recommend lifestyle modifications and follow up in 6 months. C. Start antihypertensive medication to control blood pressure. D. Order a coronary calcium score to assess risk of cardiovascular disease. Answer A. Initiate statin therapy immediately. Explanation: this patient has multiple risk factors for cardiovascular disease, including hypertension, hyperlipidemia, high LDL, obesity, and a family history of heart disease. Given his LDL level of 106 mgl, which is considered high, the most appropriate next step is to initiate statin therapy to reduce cardiovascular risk. Statins are first-line therapy. Patients with high cholesterol and increased cardiovascular risk. Option B is insufficient because, while lifestyle modifications are always important, this patient's cholesterol levels and overall risk warrant more immediate intervention. Option C is premature since the patient's blood pressure is elevated but not yet at the stage requiring immediate antihypertensive therapy. Lifestyle changes may suffice initially. Option D is not necessary at this stage. The patient already has risk factors, and coronary calcium score would not alter the management, which should focus on addressing modifiable risk factors first. Question 18. A 35-year-old male presents with a 3-week history of a non-healing ulcer on his lower leg that is associated with pain, redness, and warmth. He has a history of type 2 diabetes and hypertension. On examination, the ulcer is approximately 4 centimeters in diameter with raised erythematous borders and purulent drainage is noted. The surrounding tissue is warm to the touch. What is the most likely diagnosis? A. Venous stasis ulcer. B. Diabetic foot ulcer. C. Arterial ulcer. D. Pressure ulcer. Answer B. Diabetic foot ulcer. Explanation: this patient with diabetes has a diabetic foot ulcer, which commonly occurs due to neuropathy and poor circulation. Diabetic ulcers are typically located on the plantar surface of the foot or the lower leg and are associated with poor wound healing, erythema, warmth, and purulent drainage, as seen in this patient. The non-healing ulcer, along with the patient's diabetes history, suggests this diagnosis. Venous stasis ulcer, option A, typically occurs in the lower extremities, often near the medial malleolus, and is usually painless with an appearance of irregular borders and a shallow base. Arterial ulcer, option C, typically occurs on the toes, heels, or lateral malleolus with pale or necrotic tissue and a punched-out appearance. It is usually painful and associated with poor peripheral pulses. Pressure ulcer, option D, is caused by prolonged pressure, seen often over bony prominences and presents as a localized area of necrosis and damage, not typically associated with the features of this ulcer. Question 19. A 50-year-old male presents with polyuria, polydipsia, and unintentional weight loss over the past 3 months. His family history is positive for diabetes. His fasting glucose is 108 mdl and his HbA is 9%. What is the most likely diagnosis? A. Type 1 diabetes. B. Type 2 diabetes. C. Hypothyroidism. D. Cushing's syndrome. Answer: B. Type 2 diabetes. Explanation: This patient presents with classic symptoms of hypoglycemia, including polyuria, polydipsia, and weight loss, along with an elevated fasting glucose and H-back level. His H-back of 9% and fasting glucose of 100 mg/dL are consistent with type 2 diabetes, a condition often seen in adults with risk factors such as obesity, family history, and insulin resistance. Type 1 diabetes, option A, is typically diagnosed in younger individuals and is characterized by an absolute deficiency of insulin, leading to rapid onset symptoms. Hypothyroidism, option C, can cause weight loss, polyuria, and polydipsia, but it is usually associated with other symptoms such as tachycardia, heat intolerance, and tremors, which this patient does not have. Cushing's syndrome, option D, can cause weight gain, but it is not typically associated with the symptoms of polyuria, polydipsia, and a high H-back. Question 20. A 28-year-old female presents with a history of joint pain and morning stiffness for the past 3 months. She notes that her symptoms are worse in the morning and improve as the day progresses. Physical examination reveals swelling and tenderness in the small joints of her hands and wrists. With limited range of motion, she also has a positive rheumatoid factor and anti-CP antibodies. What is the most likely diagnosis? A. Osteoarthritis. B. Rheumatoid arthritis. C. Systemic lupus erythematosus. D. Gout. Answer: B. Rheumatoid arthritis. Explanation: this patient's presentation of joint pain, morning stiffness, and swelling in the small joints of the hands and wrists, along with the positive rheumatoid factor and CEP antibodies, is characteristic of rheumatoid arthritis. RA is an autoimmune disease that causes symmetric inflammatory arthritis, commonly affecting the small joints. Osteoarthritis, option A, is a degenerative joint disease that typically affects weight-bearing joints like the knees and hips and is not associated with morning stiffness or positive rheumatoid factor. Systemic lupus erythematosus, option C, can cause joint pain and swelling, but it is more likely to affect multiple organs and is typically associated with a butterfly rash and positive anti-nuclear antibodies. Gout, option D, usually with acute severe pain in a single joint, typically the big toe, and is associated with hyperuricemia, not with symmetric joint swelling or morning stiffness. Question 21. A 65-year-old male with a history of smoking presents with a chronic cough and hemoptysis for the past 6 months. He has lost 15 pounds over the last 3 months and complains of persistent fatigue. On examination, he appears cachectic and has clubbing of his fingers. A chest X-ray reveals a mass in the upper lobe of the right lung. What is the most likely diagnosis? A. Acute bronchitis. B. Chronic obstructive pulmonary disease (COPD). C. Lung cancer. D. Tuberculosis. Answer: C. Lung cancer. Explanation: this patient's history of smoking, chronic cough, hemoptysis, weight loss, fatigue, and a mass in the upper lobe of the lung on chest X-ray raises suspicion for lung cancer. Smoking is the most significant risk factor for lung cancer, and his symptoms and cachexia are concerning for malignancy. Acute bronchitis, option A, typically presents with a cough, but it is more commonly viral and not associated with weight. Hemoptysis or a lung mass. Chronic obstructive pulmonary disease, COPD, option B, is a common condition in smokers but would typically present with chronic cough and dyspnea without hemoptysis or a lung mass. Tuberculosis, option D, can cause weight loss and chronic cough but is less likely to present with a mass on chest X-ray in a patient with this clinical history. Question 22, scenario-based. A 40-year-old female presents with a 2-week history of a rash that started on her face and spread to her arms and chest. The rash is erythematous with a lacy, raised appearance. She reports mild joint pain and a low-grade fever. She has a history of recent exposure to a child with a slapped cheek appearance. Was the most likely diagnosis? A. Measles. B. Fifth disease erythema infectiosum. C. Scarlet fever. D. Rubella. Answer: B. Fifth disease erythema infectiosum. Explanation: this patient's rash with lacy, raised appearance and history of exposure to child with slapped cheek appearance is characteristic of fifth disease erythema infectiosum caused by parvovirus B. The rash often starts on the cheeks, slapped cheek, and then spreads to the trunk and limbs. Joint pain and low-grade fever are common symptoms. Measles, option A, presents with maculopapular rash, starts behind the ears and spreads downwards, accompanied by Koplik spots in the mouth and high fever. Scarlet fever, option C, typically presents with sandpaper-like rash and strawberry tongue following group streptococcal throat infection. Rubella, option D, causes maculopapular rash that starts on the face and spreads downwards, but it does not typically present with joint pain or lacy appearance. Question 23. A 55-year-old male presents with a gradual onset of progressive shortness of breath, especially with exertion, and a dry cough for the past 6 months. He has a history of working in construction for the past 30 years and has been exposed to asbestos. On examination, his lungs have crackles at the bases and he has clubbing of his fingers. Chest X-ray shows bilateral pleural plaques. What is the most likely diagnosis? A. Idiopathic pulmonary fibrosis. B. Asbestosis. C. Chronic obstructive pulmonary disease (COPD). D. Pulmonary embolism. Answer B. Asbestosis. Explanation. This patient's history of asbestos exposure, progressive shortness of breath, dry cough, clubbing of fingers, and pleural plaques on chest X-ray is consistent with asbestosis, a type of pneumoconiosis caused by inhalation of asbestos fibers. The pleural plaques seen on imaging are a hallmark of asbestosis. Idiopathic pulmonary fibrosis, option A, causes progressive shortness of breath but is not related to asbestos exposure and typically does not present with pleural plaques. Chronic obstructive pulmonary disease (COPD), option C, is more commonly associated with smoking and presents with chronic cough, sputum production, and progressive dyspnea. Pulmonary embolism, option D, typically presents acutely with pleuritic chest pain, shortness of breath, hypoxia, which is not consistent with this patient's gradual progression of symptoms. Question 24. A 40-year-old male presents with episodes of vertigo, tinnitus, and a feeling of fullness in his right ear. These episodes last for about 30 minutes and are associated with nausea and vomiting. On examination, there is a positive Dix-Hallprig test on the right side. What is the most likely diagnosis? A. Benign paroxysmal positional verti-BPP. B. Meniere's disease. C. Vestibular migraine. D. Labyrinthitis. Answer B. Meniere's disease. Explanation. This patient's presentation of vertigo, tinnitus, feeling of fullness in the ear, and episodic episodes lasting for 30 minutes is most consistent with Meniere's disease. The classic triad of symptoms, vertigo, tinnitus, and ear fullness, is characteristic of Meniere's, often accompanied by nausea and vomiting. Benign paroxysmal positional verti-EPV, option A, is typically triggered by head movements and for a few seconds to minute, and it is not associated with tinnitus or ear fullness. Vestibular migraine, option C, can cause vertigo but is often associated with history of migraines and may not have the episodic, recurrent nature typical of Meniere's disease. Labyrinthitis, option D, presents with acute vertigo and hearing loss following viral infection but does not typically have the recurrent, episodic pattern seen in Meniere's disease. Question 25. A 45-year-old female presents with fatigue, weight gain, constipation, and cold intolerance over the past 6 months. On examination, she has dry skin, bradycardia, and an enlarged thyroid. Her laboratory results show an elevated TSH level and low Freed. What is the most likely diagnosis? A. Hypothyroidism. B. Hypothyroidism. C. Graves' disease. D. Hashimoto's thyroiditis. Answer B. Hypothyroidism. Explanation. This patient's symptoms of fatigue, weight gain, constipation, cold intolerance, bradycardia, and an enlarged thyroid, along with laboratory findings of an elevated TH and low Freed, are classic signs of hypothyroidism. Hypothyroidism occurs when the thyroid gland produces insufficient thyroid hormones, leading to an elevation of TSH due to decreased feedback inhibition. Hypothyroidism. Option A, typically presents with symptoms such as weight loss, increased appetite, heat intolerance, tachycardia, and palpitations, which are the opposite of this patient's symptoms. Graves' disease, option C, is a cause of hypothyroidism, not hypothyroidism, and is associated with exophthalmos and at OTSH level. Hashimoto's thyroiditis, option D, is an autoimmune disorder that can lead to hypothyroidism, but it usually with thyroid antibodies and can lead to agouti. In this case, we do not have additional data to distinguish between primary hypothyroidism and Hashimoto's thyroiditis, but hypothyroidism is the most likely diagnosis. Question 26. A 62-year-old male with a history of hypertension and type 2 diabetes mellitus presents with sudden onset right-sided weakness and slurred speech. On examination, he has hemoptysis and dysarthria. The EKG of the brain reveals a hypodense area in the left middle cerebral artery, a Mackay territory. What is the most likely diagnosis? A. Transient ischemic attack TIR. B. Ischemic stroke. C. Hemorrhagic stroke. D. Migraine with aura. Answer B. Ischemic stroke. Explanation. This patient's presentation of sudden onset right-sided weakness and slurred speech with imaging showing a hypodense area in the left middle cerebral artery and chi territory is indicative of an ischemic stroke. An ischemic stroke occurs when blood flow to a part of the brain is blocked, leading to tissue damage. Transient ischemic attack tier option A involves the same symptoms as a stroke but lasts a short period, typically less than 24 hours, and there is no permanent tissue damage, which is inconsistent with this patient's findings. Hemorrhagic stroke, option C, would present with similar symptoms but is associated with hyperdense areas on CT due to blood, not a hypodense area. Migraine with aura, option D, can cause transient neurological symptoms, but it is not associated with the imaging findings of ischemia seen in patient. Question 27, scenario-based. Mr. Thomas is a 68-year-old male who has a history of hypertension, hyperlipidemia, and smoking. He presents with a 3-day history of increasing chest pain, which he describes as pressure-like and radiating to his left arm. The pain is associated with diaphoresis and shortness of breath. His vital signs are significant for a blood pressure of 159 mmHg, heart rate 98 bpm, and oxygen saturation of 94%, and Hecke segment elevation in the anterior leads. What is the most appropriate next step in management? A. Administer nitroglycerin and monitor. B. Administer aspirin and initiate heparin. C. Perform an urgent chest X-ray. D. Start a beta blocker and monitor. Answer: B. Administer aspirin and initiate heparin. Explanation: Mr. Thomas's presentation with chest pain, diaphoresis, shortness of breath, and segment elevation on ECG is highly suggestive of an acute myocardial infarction, specifically elevation myocardial infarction STEMI. The most appropriate initial management involves administering aspirin to inhibit platelet aggregation and initiating heparin to prevent further formation. Nitroglycerin, option A, is appropriate for chest pain relief, but it is not the first intervention in the setting of a STEMI. Chest X-ray, option C, is not the immediate diagnostic step for a suspected MIA. The priority is reperfusion therapy. Beta blockers, option D, may be used in MIA, but the first priority is managing the clot and initiating anticoagulation. Question 28. A 70-year-old male presents with fatigue, weight loss, and recent onset back pain. He has a history of prostate cancer that was treated with radiation 5 years ago. On examination, he has tenderness over the lumbar spine. A bone scan shows increased uptake in the lumbar vertebrae. What is the most likely diagnosis? A. Osteoporosis. B. Prostate cancer metastases to bone. C. Multiple myeloma. D. Spinal stenosis. Answer: B. Prostate cancer metastases to bone. Explanation: this patient's history of prostate cancer and back pain, along with the finding of increased uptake in the lumbar vertebrae on bone scan, strongly suggests that the pain is due to metastases of prostate cancer to the bone. Prostate cancer commonly metastasizes to bones, especially the spine, pelvis, and hips. Osteoporosis, option A, can cause back pain, but does not present with bone scan findings of increased uptake or a history of cancer. Multiple myeloma, option C, also presents with bone pain and lytic lesions, but this patient's history is more consistent with prostate cancer metastases. Spinal stenosis, option D, typically causes radicular pain and is not associated with bone scan findings or history of cancer. Question 29. A 34-year-old male presents with sudden onset severe right-sided testicular pain and swelling for the past 4 hours. He reports nausea but no vomiting. On examination, the right testicle is swollen, tender, and elevated, and there is a loss of the cremasteric reflex. What is the most likely diagnosis? A. Epididymitis. B. Testicular torsion. C. Inguinal hernia. D. Hydrocele. Answer: B. Testicular torsion. Explanation: this patient's presentation of sudden onset testicular pain, swelling, and elevation of the testicle, along with the loss of the cremasteric reflex, is highly suggestive of testicular torsion. This is a surgical emergency caused by the twisting of the spermatic cord, which leads to reduced blood flow to the testicle. Immediate intervention is needed to prevent permanent damage. Epididymitis, option A, presents with gradual onset pain and is typically associated with urinary tract infection or sexually transmitted infections. The cremasteric reflex is preserved. Inguinal hernia, option C, presents as a bulge in the inguinal region, and while it may cause pain, it is not associated with the sudden onset of severe testicular pain and loss of the cremasteric reflex. Hydrocele, option D, is a painless swelling of the and does not present with acute pain or tenderness. Question 30. A 28-year-old female presents with polyuria, polydipsia, and weight loss over the past month. On examination, she is found to have a fruity odor to her breath and is severely dehydrated. Her blood glucose level is 500 mg/dL. Arterial blood gas shows HF is 7.1, bicarbonate of 12 meckel, and an anion gap of 20. What is the most likely diagnosis? A. Type 2 diabetes mellitus. B. Diabetic ketoacidosis DKA. C. Hyperosmolar hypoglycemic state. HHS. D. Hypoglycemic crisis. Answer: B. Diabetic ketoacidosis DKA. Explanation: this patient's presentation of polyuria, polydipsia, weight loss, fruity breath, odor, severe dehydration, and elevated blood glucose with acidosis pH 7.1 and low bicarbonate is highly suggestive of diabetic ketoacidosis DKA. Life-threatening complication of type 1 diabetes mellitus DKA occurs when insulin deficiency leads to the break fatty acids, resulting in the production of ketones, which causes acidosis. Type 2 diabetes mellitus option A typically does not present with the degree of acidosis or ketonemia seen in DKA. Hyperosmolar hypoglycemic state HHS option C is more common in type 2 diabetes and presents with profound hypoglycemia but without significant acidosis or ketosis, which is characteristic of diabetic ketoacidosis DKA. Hypoglycemic crisis option D presents with symptoms like confusion, sweating, and tremors and is not associated with hypoglycemia, acidosis, or fruity breath odor.